This video reviews the techniques for examination of the older adult patient, with a special focus on functional assessment. This teaching session also demonstrates an efficient sequence of examination that minimizes patient repositioning, while emphasizing the importance of patient privacy and comfort. In the video, you will see the examiner assess a healthy patient. In clinical practice, examination may reveal normal findings or variations, or you may discover abnormal findings. Assessing the older adult presents special opportunities and unique challenges, many quite different from the disease-oriented approach of history-taking and physical examination for younger patients. In order to conduct a successful assessment, the clinician should focus on healthy or successful aging, understand and mobilize family and social supports, implement skills directed to functional assessment, often called the sixth vital sign, and promote the older adult's long-term health and safety. The health history interview is a conversation with a threefold purpose: to establish a trusting and supportive relationship, to gather information, and to offer information. You will record the patient's chief complaint, along with common or concerning symptoms. With older patients, be especially aware that cognitive impairment can affect history-taking by altering the person's ability to recognize or report symptoms. Evidence suggests, however, that when older patients do report symptoms, their reports are reliable and contain more symptoms than reports from family or collateral sources. It is best to start the assessment with open-ended questions that encourage the patient to talk about his state of health.
Tell me, how are you feeling today, Mr. Lyons?
Oh, about the same as always, I guess. Pretty good.
Okay, glad to hear that. Is there anything specific that we need to address today?
When older patients are able to report their symptoms, they may nonetheless be reluctant to report them. They may even overestimate their healthiness. The patient may be embarrassed, afraid, or eager to avoid medical expenses or the discomfort associated with treatment. Therefore, throughout the assessment, you may need to adopt more directed questions or health screening tools, as well as consult with family members and caretakers to reduce the risk of delayed assessment or intervention.
How's that shoulder view? Is it still bothering you a little?
Oh, no problem. My kids make too big a thing about that. You'd think my arm is going to fall off. No, it's a little discomfort, that's all.
Even elders with mild cognitive impairment will often provide sufficient history to reveal concurrent disorders. Use simple sentences with prompts to elicit necessary information.
Tell me about the discomfort. Do you feel it all the time or just when you use the arm?
For patients with more severe impairments, confirm key symptoms with family members or caretakers, in the patient's presence and with his consent. During your discussion, assess the patient's ability for self-care to learn whether he can perform various activities independently or with some help, or to learn if the patient is entirely dependent on others. Ask about the patient's capacity to perform activities of daily living, or ADLs, consisting of basic self-care abilities such as bathing, dressing, toileting, transfers, continence, feeding, and managing money. Then move on to inquiries about the patient's capacity for instrumental activities of daily living, or IADLs. These include higher-level functions such as using the telephone, shopping, preparing food, housekeeping, laundry, transportation, and taking medicine. You may wish to start with an open-ended request.
Tell me about your typical day. Yesterday, for example.
Well, I got up about 8 o'clock. That's when I normally get up.
Then move to a greater level of detail.
You got up around 8. How's it getting out of bed?
It's slow. I'm stiff in the morning. It takes me a while to get moving. But it gets better later on. Oh, and that's when I take my morning medication, first thing in the morning.
Okay.
Approximately 80% of older adults take at least one prescription drug each day. Roughly 30% take more than 8 prescribed drugs each day. Be sure to take a thorough medication history for each drug, including the medication's name, dose, frequency, and indications. Explore all components of polypharmacy, or suboptimal prescribing, including concurrent use of multiple drugs, underuse, inappropriate use, and non-adherence. Ask about use of over-the-counter medications, vitamin and nutrition supplements, and mood-altering drugs. Assess medications for drug interactions. When possible, it is wise to keep the number of drugs prescribed to one patient to a minimum. Managing the increasing number of chronic conditions common to older patients calls for recognizing, too, the symptom clusters typical of different geriatric syndromes. Geriatric syndromes are characterized by the interaction and probable synergism among multiple risk factors, such as falls, dizziness, depression, urinary incontinence, and functional impairment. Clinicians need to learn about these syndromes because one symptom may relate to several others in a pattern of which the patient is unaware. Searching for the usual unifying diagnosis may pertain to less than 50% of older adults.
Are you still smoking, Mr. Lyons?
Yeah, I still do.
At each visit, advise your elderly patients who smoke to quit. Keep in mind, too, that the number of older people with problem drinking is expected to rise as the population ages over the coming decades. Use the CAGE questions to uncover problem drinking.
Have you ever felt the need to cut down on drinking?
No.
Have you ever been annoyed by criticism of your drinking, perhaps from your daughter or whoever?
No, I just don't.
Have you ever felt guilty about drinking?
No, no.
Have you ever taken a drink the first thing in the morning, an eye-opener to help you to feel better or to avoid a hangover?
I can't remember the last time.
Older people often reminisce about the past and reflect upon previous experiences.
Pictures of my grandchildren taken when we were on vacation.
Listening to this process of life review provides important insights and helps you support patients as they work through painful feelings or recapture joys and accomplishments. It is important to talk with older patients about their wishes related to end-of-life decisions. Many older patients would like you as their provider to initiate this discussion before any serious illness or health emergency develops. To do this, provide information. Explore the patient's preferences. Identify proxy decision makers. And convey empathy and support. This conversation, although difficult at first, conveys your respect and concern for your patients and helps them and their families prepare openly and in advance for observing the patient's wishes for a peaceful death. For a healthy older adult patient, a complete assessment should take approximately 30 to 45 minutes. The clinician, however, must balance the need to assess complex problems with the older patient's endurance and possible fatigue, which may limit the time available to spend with the person. In such cases, the clinician should consider making ample use of brief screening tools, information from home visits and the medical record, as well as reports from family members, caretakers, and allied health disciplines. You may also wish to divide the assessment into 2 separate visits. While the patient's health and well-being should be the primary focus of the examination, be sure to promote the patient's personal comfort, too. Older patients experience physiological changes over time that require the attentive clinician to make specific adjustments to the examining room. For example, older adults are more sensitive to temperature variations than are younger adults. Therefore, make sure the room is neither too cool nor too warm. Brighter lighting allows the older adult to see your facial expressions and gestures more readily, particularly if you also sit at the patient's eye level, facing the person directly. And because more than 50% of older adults have hearing deficits, make sure the room is free of distractions and noise to ensure accurate responses and reactions. Similarly, Older adults also respond better when the pace of the examination is slow and deliberate. By demonstrating respect for the older patient, you promote the person's comfort and relaxation, which further helps to ensure a successful examination. One key to patient comfort that is of particular importance with older adults is minimizing how often you ask the person to change positions, from sitting to supine or from supine to standing, for example. The examination sequence in this video was designed to promote efficiency with minimal position changes for the patient. Another key to patient comfort is your attention to proper draping during the examination, combined with communication about your intentions as you move from one regional examination to the next. All patients will appreciate knowing why you are adjusting their gown or causing them even minor discomfort. With the patient sitting up or standing, begin the assessment with a general survey, inspecting the patient closely, literally from head to toe, in order to form impressions for your later written assessment. For the older patient, ask yourself, what is the patient's apparent state of health and degree of vitality? And what is the person's mood and affect? Note the patient's hygiene and appearance. Significant shortening of a patient's height is usually obvious by old age. Most loss of height occurs in the trunk as intervertebral discs become thinner and the vertebral bodies shorten or even collapse from osteoporosis. Flexion at the knees and hips may also contribute to shortened stature. How does he walk? And are there changes in his posture or involuntary movements? How does he move onto the examining table? Now measure vital signs. The evaluation of vital signs for older adults covers the standard areas of blood pressure, pulse, respirations, and temperature, as well as two other crucial components for this age group: pain and functional assessment. First, measure blood pressure. In Western societies, with age, the aorta and large arteries become atherosclerotic and stiffen, leading to a corresponding rise in systolic blood pressure and systolic hypertension. Diastolic blood pressure stops rising at about the 6th decade. To help you with early detection and treatment of hypertension, review the Joint National Committee's 7th report on prevention, detection, evaluation, and treatment of high blood pressure, released in 2003, which describes the 4 categories for classifying blood pressure. At the other extreme, some older adults develop a tendency toward postural or orthostatic hypotension, which may cause syncope or temporary loss of consciousness. Orthostatic blood pressure change is defined as a drop in systolic blood pressure of greater than or equal to 20 millimeters of mercury, or a drop in diastolic blood pressure of greater than or equal to 10 millimeters of mercury within 3 minutes of standing. An increase in heart rate of 20 beats per minute within 3 minutes of standing is also considered an orthostatic change. To assess for orthostatic hypotension, measure the patient's orthostatic blood pressure and heart rate in 2 positions: supine after the patient rests for up to 10 minutes, then within 3 minutes of standing. For most patients, you will simply record the patient's heart rate by checking the pulse, whereas with younger patients the radial pulse is most commonly used. With older patients, the apical method may be more accurate. Elderly people are more likely to have abnormal heart rhythms, such as atrial or ventricular ectopy, that may not be transmitted to the radial pulse. Asymptomatic rhythm changes are generally benign. Like postural hypotension, however, some arrhythmias may cause syncope. Next, check respiration. Then check the patient's temperature. Keep in mind that respiratory rate in older patients is unchanged, but changes in temperature regulation lead to susceptibility to hypothermia. Inquire about pain, commonly considered the 5th vital sign, each time you meet with the older patient.
You've been on your acetaminophen for about 2 months now, is that right?
Yes.
Okay.
Yes.
And are you currently having pain?
No, not right now.
Okay. How about in this last week?
Oh, yeah. From time to time, I have had.
Learn to distinguish acute pain from chronic pain and thoroughly investigate its cause. Although the specific goals of care may vary, a primary focus of each visit by the elderly patient is preserving the patient's functional status, the sixth vital sign. Functional status specifically means the ability to perform tasks and fulfill social roles associated with daily living across a wide range of complexity. Build upon your initial appraisal of functional status, made during the health history and reinforced during the general survey, by employing a performance-based assessment instrument. Several are available. This clinician is using a screening tool that covers 3 important domains of geriatric assessment: physical, cognitive, and psychosocial functions, addressing gait, vision and hearing, and key sensory modalities, and including questions about urinary incontinence, an often unreported problem that greatly affects social interactions and self-esteem in the elderly. As with many screening tools, office staff can easily use this particular form.
I understand you recently had a fall.
Oh, yeah. I tripped and fell in the garden.
Okay. Did you have any dizziness to warn you?
No?
Key to the successful assessment of a patient's functional status is assessing the patient's risk for falls. Fall-related assessments should include details about how the fall occurred, especially from witnesses, identification of risk factors, medical comorbidities, functional status, and environmental risks, coupled with interventions for prevention. Now we turn to the regional examinations of the older adult, with special emphasis on changes of aging. Inspect the patient's skin. Note physiologic changes of aging, such as thinning, loss of elastic tissue and turgor, and wrinkling. With age, the vascularity of the dermis decreases, causing light skin to look paler and more opaque. Skin on the backs of the hands and forearms appears thin, fragile, loose, and transparent. Nails lose luster with age and may yellow and thicken, especially on the toes. There may be purple patches or macules, termed actinic purpura, that fade over time. These spots and patches come from blood that has leaked through poorly supported capillaries and spread within the dermis. Look for nevi, scars, or other distinguishing characteristics, noting their placement and dimensions. Although several benign lesions commonly develop with age, elderly people may also develop skin cancers. When you see nevi or moles, assess for skin cancer using the ABCDE method. Inspect for asymmetry, irregular borders, color variation or change, especially blue or black, diameter larger than 6 millimeters, and elevation. If any of these 5 aspects is positive, refer the patient to a dermatologist for further evaluation of possible melanoma or other skin cancers. In older bedbound patients, inspect the skin also for erythema, bruising, or ulceration. Next, assess the head, eyes, ears, nose, and throat. Palpate the scalp and inspect the hair and its texture. With age, scalp hair loses its pigment, producing graying. Hair loss on the scalp is genetically determined. Less familiar, but probably more important clinically, is normal hair loss elsewhere on the body, such as the trunk, pubic areas, axillae, and limbs. Inspect the face and palpate for sinus tenderness by pressing up on the frontal sinuses from under the bony brows. Then press up on the maxillary sinuses. Inspect each cornea, iris, and lens. Check the color of the conjunctiva and sclera. Observe any ptosis. Check the lower lids for ectropion or entropion. And note yellowing of the sclera and arcus senilis. Compare the pupils and test their reactions to light and accommodation. Inspect each lens carefully for any opacities. Do not depend on your flashlight alone to make a diagnosis of cataract, because the lens may look gray, as if opaque, when in fact it permits good visual acuity. Note that normal older adults experience physiological changes to the tissues in and around the eyes, and near vision in particular begins to blur noticeably, even though visual acuity overall normally remains adequate. With an ophthalmoscope, inspect the ocular fundi. In older adults, the fundi lose their youthful shine and light reflections, and the arteries typically look narrower, paler, straighter, and less brilliant. Next, proceed with inspections of the nasal surfaces, nasal passages, ear canal and drum, and mouth. Pay particular attention to the floor of the mouth and the sides and undersurface of the tongue, for here is where cancer may develop. Inspect the neck. Then, with the patient relaxed, palpate the lymph nodes in the anterior cervical chain and above the clavicle.
Can you bend your head forward for me, please?
Next, palpate the posterior cervical chain. The frequency of palpable cervical nodes gradually diminishes with age, and according to one study, falls below 50% between 50 to 60 years. In contrast to the lymph nodes, the submandibular glands become easier to feel. Next, palpate in the sternal notch to check the position of the trachea. It should be midline. Inspect for, then palpate, the thyroid gland. Positioned behind the patient, continue by inspecting and palpating the muscles of the upper back. Note any kyphosis in the upper vertebrae, arising from changes in muscle and bone mass. Then, inspect and palpate the chest. Percuss the lungs. And the posterior thorax. Assess respiratory excursion. As people age, their capacity for exercise decreases. The chest wall becomes stiffer and harder to move. Respiratory muscles may weaken, and the lungs lose some of their elastic recoil. Lung mass declines, and residual volume increases. The speed of breathing out with maximal effort gradually diminishes, and cough becomes less effective. Next, auscultate the posterior thorax. Observe the rate, rhythm, depth, and effort of breathing, and listen for adventitious sounds that may indicate abnormal respiratory conditions. Having already examined the patient's hands and upper back, you may decide that more extensive musculoskeletal and neurological examinations of the upper extremities are warranted while the patient is still sitting. If so, examine the temporomandibular joints.
Okay, very good. You bend your head forward, bend your head
Neck.
backwards. Okay, good. You want to put it back neutral to the right and to the left. Okay, very good. That doesn't bother you, I hope. Okay.
Hands.
Take a look at your hands here. No pain in these areas as I'm palpating them at all.
Wrists.
Let's bend this wrist back and forth. That doesn't bother you particularly. Okay, let's see.
Elbows.
No problems with some tenderness there. Bend. Very good. Let's go to this other side. Your shoulder.
And shoulders. Inspect and palpate the joints. Then check their range of motion. For the shoulders, assess external and internal rotation.
Okay. I'd like you to do this motion with your arms.
Aging may affect all aspects of the nervous system, from mental status to motor and sensory function and reflexes. Most elderly people do well on the mental status examination, but selected impairments may become evident, especially at advanced ages. Next, with the patient still seated, you can perform a neurological examination of the patient's mental status, cranial nerves, and upper extremity motor function. First, visually assess the patient's bulk. Then check muscle tone and assess strength of the biceps and triceps muscles.
Don't let me pull your arm out. Very good. Push against my hand. Okay, very good. Excellent. I want you to make a muscle over here. Don't let me pull it out. Very good. Push against my hand. Excellent. Very good job. Okay,
And the
good.
patient's hand grips.
Squeeze my fingers hard. Okay, very good. Excellent.
Next,
Put your
check
arms
for
out.
pronator
Spread
drift
your fingers. Close your
and
eyes.
assess fine motor coordination.
Keep your eyes closed. Okay. Very good. With your eyes still closed, please. What I want you to do is take your index finger, touch the tip of your nose with first the left hand, then the right hand, then the left hand, then the right hand, alternating as rapidly as you can. Can you do that? Very good. Okay, you can open your eyes. Okay.
Check the patient's rapid alternating movements using a technique such as that demonstrated. Together, these exercises help you assess the patient's upper extremity strength and coordination while the person is still seated.
Okay, Mr. Lyons, I need you to lay back for me, please.
Now help the patient to change to the supine position for examination of the anterior thorax, lungs, and cardiovascular system. Examine the anterior thorax and lungs and note any subtle signs of changes in pulmonary function. Increased anteroposterior diameter, percept breathing, and dyspnea with talking or minimal exertion suggest chronic obstructive pulmonary disease. With the patient supine, begin the cardiac examination. A good cardiovascular examination requires more than observation. You must think about the possible meanings of your individual observations, fit them together in a logical pattern, and correlate your cardiac findings with the patient's blood pressure, arterial pulses, jugular venous pulsations, the rest of your examination, and the patient's history. Aging may affect the location of the blood pressure and stiffness of the arteries, the apical impulse, and the pitch of heart sounds and murmurs. One of the most important and frequently used skills of physical examination, and often the first step in your cardiovascular assessment, is estimating the jugular venous pressure, or JVP. Be sure to distinguish the undulating jugular waveform from carotid artery pulsations. Next, assess the carotid pulse. Your assessment will include both palpation and listening for bruits. In older adults, systolic bruits heard in the middle or upper portions of the carotid artery suggest, but do not prove, partial arterial obstruction from atherosclerosis. Carotid bruits in the elderly warrant further investigation for possible carotid stenosis. Inspect and palpate the anterior chest for any heaves, lifts, or thrills. Then palpate left and right second interspaces close to the sternum and feel for a right ventricular impulse in the left peristernal and epigastric areas. Note any thrills in these areas. Assess the point of maximal impulse, or PMI. Then auscultate S1 and S2. Listen also for the extra sounds of S3 and S4. Beginning in the second right interspace, listen for cardiac murmurs in all 6 areas of auscultation. Describe the timing, shape, location of maximal intensity, radiation, intensity, pitch, and quality of each murmur you detect. Turn the patient to the left lateral decubitus position to listen for the lower pitched sounds of an S3 or the diastolic murmur of mitral stenosis. Then, with the patient seated and leaning forward, listen along the left sternal border and at the apex for the soft decrescendo diastolic murmur of aortic insufficiency.
Okay, very good.
Examination of the breasts is important for both female and male patients. While the techniques of examination for men and women patients are similar, the female breast is usually more dense, and its examination should, therefore, be more thorough. The size and shape of normal breasts in the adult female vary widely as a result of heredity, age, nutrition, endocrine activity, parity, and history of lactation and pregnancy. Typically with age, the female breasts tend to diminish in size and become flaccid and more pendulous. Inspect the breast, nipple, and areola. Palpate the breast carefully for lumps or masses. Palpate in the tail of Spence that extends into the axilla, and examine the axillae for lymphadenopathy. Finally, palpate the nipple. Repeat on the other side. Although inspection and palpation of the male breasts, nipples, areolae, and axillae may be brief, they should not be omitted. When examining the abdomen of older adults, keep in mind that fat tends to accumulate in the lower abdomen and near the hips, even when total body weight is stable. Occasionally a person notes the change with alarm and interprets it as fluid or evidence of disease. Inspect the abdominal contours. Note that for the abdomen, auscultation comes before palpation. This is different from other regional examinations, in which palpation precedes auscultation. In the abdominal examination, palpating prior to auscultation might distort the quality of bowel sounds. Listen for abdominal or femoral bruits. Check for any bruits over the aorta, renal arteries, and femoral arteries. Next, lightly percuss the abdomen to assess the distribution of tympany and dullness. As you apply light, then deep palpation to the abdomen, observe the patient's face closely for indications of tenderness or discomfort. Old age may blunt manifestations of acute abdominal disease. Pain may be less severe. Fever is often less pronounced, and signs of peritoneal inflammation may be diminished or even absent. Palpate near the midline for any aortic pulsations. Try to assess the width of the aorta by measuring the distance between your palpating fingers. Now complete your examination of the peripheral vascular system by palpating the popliteal, dorsalis pedis, and posterior tibial arteries. Although arterial and venous disorders, especially atherosclerosis, do affect older people more frequently, they probably cannot be considered part of normal aging. Peripheral arteries tend to lengthen, become tortuous, and feel harder and less resilient. These changes do not necessarily indicate atherosclerosis, however, or pathologic changes in the coronary or cerebral vessels. With the patient remaining supine, examine the hips, knees, ankles, and feet for any changes indicating degenerative joint disease or other joint conditions. You can now complete your neurological examination by further assessing the lower extremities, including motor strength, sensation, and upper and lower extremity reflexes. Frequently, the clinician must try to distinguish age-related changes in mental status from manifestations of specific mental disorders whose prevalence increases with aging, such as depression and dementia. Genital and rectal examinations are performed based on specific findings, concerns, and symptoms relative to the individual patient. The techniques of examination are the same as for younger adults, as shown in Volume 8 of this series, Male Genitalia, Hernias, Rectum, and Prostate, and Volume 9, Female Genitalia, Anus, and Rectum. The genitalia of older women will reflect changes related to menopause, such as thinning of the skin, loss of pubic hair, and decreased distensibility of the introitus. Look for labial masses. Bluish swellings may be varicosities. Bulging of the anterior vaginal wall below the urethra may indicate a urethrocoele or urethral diverticulum. Look for any vulvar erythema. Inspect the urethra for caruncles or prolapse of fleshy erythematous mucosal tissue at the urethral meatus. Note any enlargement of the clitoris. When examining older men, pay special attention to any rectal masses and any nodularity or masses of the prostate. The anterior median lobes of the prostate are inaccessible to rectal palpation, limiting the utility of digital rectal examination for detecting prostate enlargement or possible malignancy. Keep in mind that symptoms of urinary hesitancy, dribbling, and incomplete emptying can often be traced to causes other than benign prostatic hyperplasia, which is the proliferation of prostate epithelial and stromal tissue. These other causes include coexisting disease, use of medication, and lower tract abnormalities. In summary, the assessment of the older adult patient builds on the methods you have already learned for the general physical examination of adults, but highlights special techniques for older patients when conducting the health history interview, surveying general appearance, measuring vital signs, and completing each regional examination of the older patient's body. By practicing a functional and systematic assessment of your elderly patients, you can promote and protect the health and well-being of the fastest growing segment of our population, older adults.